Good evening, Dr. Sitati.
Good evening to you.
I have permitted you.
Okay, thank you.
Yes.
Trying to. So it's taking me in circles with this axis. Somehow it's not accessing the. Give me a minute. I check the other computer.
Okay.
Now I'm writing messages.
Can give me like 5 minutes. I'll open the other computer, then we can start. Eh?
Okay, doctor. Dr. Sitati,
Yes, Can. Give me a few minutes. Just hold on. I can see we have good outcome. It will not be fair. Yeah.
if you're having difficulties, maybe you can reply to that email with the
Yes.
presentation and I can present.
Ah, good idea. Oh, you should have told me earlier. Because I'm opening on the computer, this one has a glitch of some sort. Let me reply with the, yeah, good idea. So now I'm trying to load it. Yeah, I've sent it to you just now. You could opt for that idea. Can you? Perfect. It won't be long, don't worry. Thanks for being patient.
Can you see it?
Yes, I can see. However, I'm seeing them 3 slides already. Are you able to
You want
project
it?
one slide?
Okay.
Okay, no problem. We can. It came as a PowerPoint.
Presenting on my phone, so it will have to. I'll have to slide through it.
No problem.
Recording in progress.
Sorry for that delay. My name is Dr. Sitati. I'm a senior lecturer in the Department of Orthopedic Surgery. And so we'll briefly go through, we're looking at the injuries of the forearm, wrist, and hand. And our first objective we'll be looking at history and physical examination for the hand injuries. We'll also look at orthopedic injuries in terms of the forearm, wrist, and hand as shown. And when you think of orthopedic injuries of the upper limb, particularly the hand and wrist, look at it in terms of tendon injuries, bites, fractures, and as well as also we look at the treatment options and also complications that can happen in such injuries. So history and physical examination is important, of course, for any injury. To make any diagnosis in medicine, you need to take a thorough history, physical examination. Then from there, you treat. In the history, when someone presents with hand, wrist, and forearm injuries, you must find out the mechanism. How did it happen? Was it a road traffic accident, fall from height, an assault? That should be clearly documented in the history. What time of the injury? Was it yesterday, 1 month ago, last 1 year ago? Was the wound clean or dirty? Or possibly there may even be no wound. Check on the tetanus immunization status. Right-handed. You have to check the occupation of the patient and also the function before the injury. Did they have any other issues? Comorbidities like diabetes, hypertension, asthma. We know very well many of these comorbidities affect function. For example, a patient with diabetes will have high risk of getting infection, so one has to be careful. Check the last meal in case they need to go to theater. I've put in red. That is very important to thoroughly examine them, do thorough inspection, compare with the opposite side, check abnormal positioning, check for open wounds, check capillary refill and pulse, check range of motion, both active. Active means the patient is able to do it themselves. Passive means you do it for the patient, checking the range of motion. Check neurological function, that is how the nerves are working, both the motor function. Last but not least, check for joint stability. Now going to the specific areas, as I said before, when you look at hand, wrist, forearm injuries, you look at tendon injuries, bites, fractures, and dislocations. With regards to tendon injury, the mechanism of injury may be direct laceration. For example, someone could be crash injury from a machine, could be avulsion, burns, bite, or even deep abrasion. This can affect the tendons. Treatment, of course, in cases where there is an open wound, you must give tetanus prophylaxis, you must give antibiotics. Of course, tetanus prophylaxis is given to prevent tetanus, and your antibiotics to prevent infection. You do appropriate x-rays to determine whether there are bony injury. In theater, we'll do thorough debridement and irrigate the wound in case it's a wound. And if no wound, we'll go straight ahead and repair the tendons. And sometimes you may need to do debridement initially, then come later on to do once the wounds look not infected, you can now do the tendon repairs. Usually use non-absorbable suture like nylon to repair tendons. Next, we move to the back. It can be human bite, can be animal bite. And it is said animal bites, human bites are even worse than animal bites, possibly because of the human oral cavity has many more bugs. So treatment, of course, many cases there'll be a wound, must be thoroughly debrided. And even before that, you must give tetanus prophylaxis if it's an animal and the rabies immunization status is unknown. Maybe a stray dog rabies vaccine is given. X-ray is done again to determine whether there is bony injury, and again you refer to orthopedic surgeon who will sort out whether there are tendons or bones involved. And it's important to note that the wounds should not be stitched early. There is high risk of infection when you stitch the wounds. Following bite injuries, I will also mention both bone form fractures, that is, means fracture of the radius, and mechanism of injury in most cases is a direct blow to the forearm. Could be an assault, could be an RTA, fall from some height, landing on the forearm. Treatment, when they're displaced, you do ORIF, that is open reduction internal fixation, usually with plates and screws. In the rare situations where they're not displaced, plaster, above elbow plaster, or forearm fractures in both bones include not only compartment syndrome, but also malunion. For nightstick fracture, a nightstick fracture refers to an isolated fracture of the ulna. So in such situations, the ulna may fracture. Common mechanism is a direct blow to the ulna. At night, someone is attacked and they put their hand up so as to block their face. Whatever object is being used to attack the person, hits the ulna and it fractures, and you get a fracture ulna known as a nightstick injury or nightstick fracture. Treatment: if non-displaced, you immobilize in a cast. If displaced, you do open reduction internal fixation. The next forearm injury one may get is a Galeazzi, and Galeazzi was a gentleman who described this injury. Fracture, it will come in your MCQs or even in the OSCE at any point, that a Galeazzi is a fracture of the distal radius with the dislocation of the distal radioulnar joint. So it's also referred to as a reverse Monteggia fracture. Mechanism usually is direct blow to the wrist or fall on the outstretched hand, and the common complication that may occur is ulnar nerve injury. For this, as you can see on the radiograph there, that's the wrist joint, that's the radius, that's the ulnar, and these are the carpal bones, that's the metacarpal bones. You can see that that joint is definitely dislocated. There's also hidden behind there is that fracture of the distal radius. Okay. So Galeazzi fracture must be treated operatively. You do open reduction. Examinogenic, that Monteggia fracture is a fracture of the proximal ulna. You can see the fracture there with the dislocation of the if you do more proximal of the radial head. Okay, fracture of the proximal ulna, dislocation of the radial head is known as Monteggia fracture, usually due to direct blow to the posterior aspect of the ulna or even fall on the outstretched hand. The radial nerve may be injured. For this, again, reduction, internal fixation. The next, after Monteggia fracture, the next we'll talk about is a Colles fracture. Again, these are eponyms. Colles fracture is an eponym. Monteggia, Galeazzi, all these are eponyms. Conditions named after people who described them many years ago. This Colles fracture specifically refers to transverse fracture of the distal radius with dorsal on the outstretched hand, and it's common in patients more than 50. And usually when you examine, you find a dinner fork deformity. Dinner fork, that is classic dinner fork deformity, looks like a fork, you know, that goes like that, and dorsal displacement. There may be median nerve injury. Remember, the median nerve passes on the volar aspect of the radius, so it will, that radiograph is showing clearly a lateral view of the wrist and hand, and you can see that there is dorsal displacement. That's a Colles fracture. Treatment: if it is not displaced, we just use a sugar tongue splint or a plaster. If displaced, then you must do close reduction and put a cast. Or if you find it's unstable when you try to do close reduction and casting, then you do open K wires or for the Colles fracture. The opposite of Colles fracture in terms of displacement of the distal fragment. Remember, we say that Colles, there is dorsal displacement. In a Smith fracture or Smith's fracture, there is polar or anterior displacement of the distal fragment. So remember, we said Colles, there is dorsal or posterior displacement, giving a dinner fork deformity. Smith's fracture is usually also mechanism is fall on the outstretched hand. Treatment, again, similar. If non-displaced, you put a plaster. If displaced, you do close reduction and cast. And if it is unstable, it's not holding well in the cast, you may put K wires, or you do open reduction and internal fixation and put plate and screws. Next, we move to identify the different couple bonds. There are various mnemonics. Do you know any mnemonic for these bonds? Or ask your best friend, Barwaka. You remember the mnemonic according to Dr. Ori? So all these couple bonds can fracture, and the commonest bond that may fracture that fractures in the carpus is a scaphoid, and usually again mechanism fall on the stretched hand or abnormal loading of the thumb, and you find it tenderness in the anatomical snuff box. Treatment is that like a splint. If it's displaced, again, it will require ORIF. You can use K-wires or you can use a special screw known as a Bennett screw. So that next diagram shows clearly the arrow there is clear. That's the scaphoid bond radius there. That fracture there is clearly shown. This one is displaced. You need to put like a screw or a K-wire known as a Hubbard screw that compresses that and closes the gap. The couple fracture, you can see this fracture of that is the thumb there. Example stock of the thumb number 1, 2, 3, 4, 5, but that's not highly recommended. Better talk of just the thumb, index finger, middle finger, ring finger, and little finger. So in this, you can clearly see in this AP view fracture of the index finger. That's the mid shaft fracture. That's the middle finger. It's a spiral fracture. And here it's not. Yeah, so those three metacarpals are fractured. This one will work. It's not displaced much. Will heal in a cast. Boxer's fracture refers to fracture of the fifth metacarpal. And if it's not displaced, plaster will suffice. If displaced, again. So displacement is key in making a decision whether to do ORIF or to do just a plaster. Mallet finger refers to a diagram shows clearly that this extensor tendon, which attaches to the base of the distal phalanx, has pulled out or avulsed, can be with a bone or no bone. And usually treatment is to splint 6 weeks in extension so that it heals. If that fails, there's an option of doing ORIF. Finger dislocations also occur where there is direct trauma to the tip of the finger due to do close reduction and splint. You can see that diagram there. That finger, definitely when you see a finger like that, you know that there's something wrong. Make sure you take a thorough history and find out the patient was not born like that, because you may try forcing a congenital abnormality. So you establish it as a traumatic injury, deformity, and then you do rest, ice compression, elevation. You do a close reduction and you splint it, usually maybe for 3 to 6 weeks, and after that, all is well. If there's a tendon injuries, you need to address them, but most cases, splinting is sufficient. Next is the wrist sprain, and there are various ligaments that hold the wrist together. The wrist can be strained due to fall on the extended wrist. Repetitive wrist extension and hyperextension can occur in some occupations, or also weight bearing on the wrist in a wrestler or gymnast. And wrist taping, which is a type of splinting. And if then an operative treatment fails, then there is role for surgery. Good. Next, we go to complications of fractures. We know that whenever there's a fracture, there's an ligament injury, complications may occur. And they are divided into general or local, and then local is further subdivided into early complications, which occur days to months later. The next slide is a busy slide, but won't go into details. I'm sure you later on in your time you'll look through. You can see general. There are like 4 complications. Local, of course, depends on the severity. You're not likely to get hemorrhagic shock when you get fracture of the scaphoid, but tetanus is possible if you have a wound. Gas gangrene is possible. Even fat embolism if you get maybe a serious injury to the radius. As I said, are divided into early and late. I will allow you to look at those tables and internalize. This is a very important table. We always ask about complications in all our exams, so make sure that you look at this table critically and understand it. Thank you for listening. That's all for now. Sorry for the delay. I hope Khan, you'll share the slides and so that people can internalize. And thank you. Any burning question?
Just check the chat box.
Oh, you have some question in the chat.
I'm just checking. I don't think anyone has posted.
Okay.
Look, you had mentioned that, let's say in the finger dislocation, if it is a congenital malformation, then we just leave it. Yeah.
Yes,
Why is that?
The thing is, if a child is born like that and comes as an adult, meaning it's been there for so long, it means it may need some surgical intervention if they want it corrected. So you either leave it alone, but you have to take thorough history and examination to make sure that you're not trying to force a congenitally crooked finger. But the crookedness or deformity is actually acute and traumatic nature.
So if it's acute, then you just do the closed reduction with the splint.
Yes, exactly.
Yeah. Okay. Okay. I don't think there's any questions.
Okay.
Thank you so much for your time this evening, Doctor.
Oh, I can see some. Is it advisable to remove screws or plates later? That's a very good question, Brian. There's controversy about removal. There's a study done among British orthopedic surgeons, and they are being asked, do you routinely remove plates and why? So 50% of orthopedic surgeons tend to routinely remove plates and screws, and the 50% don't routinely remove. However, if one removes, you want to remove after 1.5 to 2 years and it has fully healed. Okay. So there's that controversy. In some situations, if there's infection, discomfort, sometimes the patients feel lots of cold whenever, if they have a plate inside there, they feel cold around the plate, you may remove. So that it's important to know that. However, if you do knee replacement, hip replacement, those implants are not removed. They're functioning as joints. Hip, knee replacement, ankle replacement, shoulder replacement, those remain for life. I hope I've answered your question, Brian. You're welcome. Maybe from Chodo. So, Khan, how many are in your class?
We our attendance usually is around 300 and something.
Okay.
But like I had mentioned to you, there are some students doing their presentations today at the end of rotation.
Okay.
So they're still at it.
How is your class? How many in level 4?
We're 470 or 80.
Number.
Yeah.
That's MBCHB.
MBCHB 4.
Okay, good. Thank you for listening. Share with the rest the PowerPoint, share the recording, and have a lovely evening.
You too. We will meet tomorrow then in the morning.
Yes, please. Yes, 8 o'clock. Remember?
Yes.
You got a room?
I just hope they show up early with the keys.
Good. If not, we go up. Thank you. Have a good evening.
Have a good evening.
You're
to you.
welcome.
Thank
Bye-bye.
you. Great.
Recording stopped.